Marcia Patrick is currently a surveyor for the Accreditation Association for Ambulatory Healthcare with a master's in nursing from the University of Texas and 30-year experience in infection prevention.
Bob, thanks for that warm welcome, and welcome to everybody here this afternoon. I've been doing infection control for like 35 years, and I became aware of some of the changes going on in your industry when I was doing research for a different talk, and I became totally engaged in looking at what we're doing with ultrasound. I worked in big health systems with multiple outpatient clinics, tertiary referral, teaching hospitals, and small hospitals, and lots of clinics. So what we see in these areas is ultrasound use is growing and growing every day. They find some other wonderful use to help patients using ultrasound. So at the conclusion of the presentation, objective is there to be able to describe the infection risk across diverse sonography locations and applications, and we'll talk about the second one as we go through. So we know from many, many studies, and they're all referenced, the articles are all there for you. We know that Doppler probes can be contaminated with disease-causing pathogens. We know that the intracavity probes, in one study, 21% of them were contaminated after using a low-level disinfectant wipe, one of the pop-up wipes. And after disinfection with wipes or sprays, somewhere around 13% had bacteria and 1% had viruses on them. So, that gets to be a little alarming, and probably one of the worst places is the emergency department. And I know that often as a nurse, the mentality there is we're too busy to deal with some of these petty little issues. And unfortunately, they're really not petty little issues when you're the patient. 57% of the probes across 5 EDs and 5 intensive care units, who also have that mentality, I have worked in ICU, were contaminated with blood, so that's a bad thing. And 48% of probes across 5 EDs and the ICUs had bacteria on them. And again, the references are all there. So we know that this is an issue. Over in Great Britain, a patient died from hepatitis B from an improperly processed semi-critical probe. We'll talk more about those. And the United Kingdom issued their Health and Human Services issued instructions across the country to review and revise these instructions for cleaning as necessary for probe reprocessing. And there's been cases of hepatitis C transmission with endocavity ultrasound probes during both prostate biopsy and assisted conception. Can you imagine trying to get pregnant with assisted conception, and you might get pregnant, but oh, by the way, we gave you hepatitis? Sorry about that. Yeah, not a good thing. And these were related to poor semi-critical ultrasound probe disinfection. And I'm going to describe what those words mean in a second here. You guys could probably add to this enormous list of places that now use ultrasound. It is so pervasive, and it has changed over the years from being essentially non-invasive to often a very invasive procedure. There are lots of guidelines and standards that apply to processing of ultrasound probes. The Centers for Disease Control, and I will show you a health alert network that was sent out in 2015, the Food and Drug Administration, the Joint Commission, and the other accrediting agencies like AAAHC, Quad ASF, et cetera, DNV, all of those, as well as AAMI. And they are the Bible writers, if you will, for disinfection and sterilization, and their products are available at the aami.org website. So most of these are in harmony with each other. They agree with each other on ultrasound reprocessing. And the key here is it is not intracavity versus surface probe. It's about the intended use of the probe, and I'm going to talk about that a little bit more with the Spaulding criteria. Back in 1972, Dr. Earl Spaulding came up with a scheme for processing instruments based on the intended use of the instrument. So critical devices are those that enter the bloodstream or sterile body sites. So invasive ultrasound and where a needle is going to go through the skin or go into the bloodstream, those need to be sterile. Those need to be sterile. And I have some pictures I'm going to show you that kind of don't show that it's sterile. Semi-critical are those probes that touch mucous membranes, so anal and vaginal ultrasound probes, things like that. And then the non-critical probes are those that touch intact skin. How many of you do OB? Yeah, a lot of you do OB. One of the things that we see, you know those big containers of gel? It's like a 3-gallon plastic thing, and people refill their bottles from that, and then they put them in what I call an incubator. You call it a warmer. I call it an incubator. Often those are refilled by the sink because sometimes it glops over and you don't want to get it on the floor or the counter, so you do it over the sink. The top of the ultrasound bottle gets put down on the sink surface or next to the sink that's contaminated with water bugs, Pseudomonas, and everything else. And then it gets put on the top of the bottle, and then the bottle goes back in the incubator so that by the time it gets used, it is absolutely loaded with bacteria. But then we say, well, but this is a non-critical, it's going to be on normal intact skin. How many of you have had a pregnant patient come in for ultrasound and go to the delivery room because they are having a placenta previa or some bad thing is happening to them and they need an immediate C-section, and having been in on C-sections, all they do is grab a bottle of betadine and they squirt it over the abdomen and cut to save the baby's life. That is appropriate. But if your ultrasound gel that is loaded with Pseudomonas or Serratia or Klebsiella or E. coli is all over their abdomen, and it was wiped off maybe with a towel but not scrubbed off, we wonder why we see C-section infections. And I know that was something we were dealing with when I was at Multicare, was those C-section infections. And I never thought about the ultrasound gel until I was working on a talk. So something to think about. Those big containers of the goo aren't good. Buy the bottles that are pre-filled and throw them out when they're done. Don't refill them. It's just not a safe thing to do. So again, critical enters the bloodstream or sterile body sites like going into the thyroid or to a joint or another body site. Semi-critical are those mucous membrane things, and then the non-critical are intact skin, but we still have an obligation to do that safely. And, you know, we've always considered ultrasound a very safe and very valuable procedure. The probes themselves have all kinds of sizes and shapes and material, and their construction is different. You know, and new things, again, come out every day. As we've already talked about, we use it on intact skin as well as non-intact skin and in invasive procedures. And if we're going to put it in a sterile body site, it goes from non-critical to critical. If we're going to use it in mucous membranes like anal and vaginal ultrasound probes, those are considered semi-critical and require high-level disinfection. So low-level disinfection is what we do for environmental surfaces. It's what we wipe off stethoscopes with, we wipe off blood pressure cuffs, you know, all the, you know, tabletops, overbed tables, countertops, and the pop-up wipes are fine for that. They need to be EPA approved as a hospital disinfectant, and they need to be used per label instructions. And the two things that I see with the pop-up wipes that people don't do correctly. The first one is the wet contact time. It has to stay wet for whatever the canister says is the wet contact time. Sometimes that means you have to re-wipe, and the higher the alcohol content, the more likely it is you'll have to re-wipe with a fresh wipe. The second thing is I see people using a wipe on one surface and then they take it and they do another surface and another. You can't do that. It's a one wipe or two or three, however many you grab, per surface, and then you get discarded and you pick another wipe for the next surface. Otherwise, you're just moving stuff. You know, studies have shown you just move stuff from one place to another, and that's probably not a good thing. So some of the probes, we talked about transabdominal scans, other surface scans, and those low-level disinfectants kill most vegetative bacteria and viruses, except for some of the bacterial spores. So that's not usually what we're concerned about with intact, normal skin. We don't worry about that. And so the low-level disinfectants are fine for that purpose. High-level disinfection, which is the killing of all viable microorganisms except for large numbers of bacterial spores, is required for anything that's going to touch mucous membranes. So again, anal and rectal vaginal ultrasound probes, TE probes, that kind of thing. If you've got broken skin, it goes into that category because it's only for intact skin that you can use a low-level disinfectant. So there may be times when you have to high-level disinfect a probe because you ended up with somebody who had badly non-intact skin, and often with leg ulcers and things like that, that can happen as well. Burn graft evaluation too. I didn't even know they used ultrasound for burn grafts, so learn something new each time. So in addition to sterilization or high-level disinfection, when we're using probes and there's going to be a needle that's going to go through the skin, so if it's going to enter a sterile body cavity or the vascular system, it needs to be high-level disinfected, and you need to use a sterile sheath and sterile single-pack ultrasound gel, because what I have in the pictures that follow, and I was talking to Bob about this, and he said, yeah, the needle often goes through the ultrasound gel into the thyroid or the whatever body site you're going into. So that means you need to use sterile single-use packet ultrasound gel for these kinds of procedures. So these were just pictures that I pulled off the internet. You know, I Googled. And you can see, yeah, the Google, yay. You can see in some of these pictures that we have penetration, we have a needle going in, and we have bare hands instead of sterilely gloved hands. That's a vascular access in the upper right-hand corner. Again, no gloves. I don't see a cover on the ultrasound probe, and of course I can't tell what the gel was that was used. Now the lower one, there's gloves, and I don't see a sheath, but there could be one there. It's not the best picture in the world, but you can see where things are done incorrectly on top and better on the bottom. So just some things to think about. And my buddy Bob here said that if you don't have a sterile sheath, you can use a sterile glove. Yeah, you can just use a sterile glove. So something to think about. So the vaginal and anal ultrasound probes, there have been multiple studies that have identified all kinds of bad organisms on the probes. I mean, disgusting. After disinfection. Probably the big one right now is human papillomavirus, and there's some evidence that products like glutaraldehyde and OPA don't do a good job of killing human papillomavirus, which is responsible for like 95% of the cervical cancer in the world. And there are vaccines for young people for that, for age 11 and 12, and I know a lot of people were concerned about that, but they've shown that you can transmit human papillomavirus just by playing with your hands. You don't have to have penetrative intercourse. That's a big word for sex. So we need to be sure to get our kids immunized for this pathogen because it does cause cancer, and it's an awful disease. And I would be very upset if I ended up with HPV because I had a vaginal or an anal ultrasound probe. You know, that just is not a good thing. Chlamydia, mycoplasmas, bacteria, fungi, other viruses, there's a whole slew of organisms that have been recovered. Usually these are used with a sheath or a condom. I hope you are doing that. The commercial sheaths that come with the products often have a very high failure rate. They range from 2 to 8%. Often a good quality condom is a better cover than the ones that come with the devices themselves. So just a word to the wise. Multiple studies show presence of organic matter even when you're using the cover. Some countries in Europe do not high-level disinfect these. They low-level disinfect, but in the United States, the CDC requires, and the Spalding classification requires, at a minimum, high-level disinfection. I just love this. And I'm old enough to appreciate it. So our second objective is to establish ultrasound probe disinfection procedures that will ensure patient safety and meet accreditation requirements. But notice, patient safety first. This is all about patient safety, staff safety. So I mentioned that the CDC and the FDA put out a health alert from the Health Alert Network back in 2005 to have facilities review their policies and procedures and processes for high-level disinfection, and that they were following the Spalding criteria that we've talked about, because they were seeing so many lapses and failures in their surveys and things that CDC was doing. And the Joint Commission also had put out an alert previously in 2014 as well on improperly sterilized or high-level disinfected equipment. So what are surveyors looking for? Yeah, we're out there looking for this stuff. And I survey for AAAHC, but I also know Joint Commission is all over this as well. And there is the CMS Infection Control Surveyors Worksheet for ambulatory. You can just Google that and you'll get it. The most recent version is July of 2015. They change it periodically, so be aware. But you can self-assess using that Infection Control Surveyors Worksheet. So what we're looking for with your cleaning, disinfection, and sterilization practices is, do you have the manufacturer's instructions for cleaning and disinfection, and are they adequate? I have seen facilities buy, and this isn't high-level disinfection, but buy these wonderful touch screens, you know, computer system touch screens to use, and there is no way to disinfect the screen without ruining it. So that's why infection prevention needs to be at the table when you're looking at buying new devices and stuff. There are some ultrasound probes that you cannot submerge the handle, they're not sealed. And that's a problem because you can't deal with the handle. They want to see that you're following the manufacturer's instructions for use. So you need the current ones, and processes do change, so be sure you have the most current instructions and that you're following them. I've been in facilities, they have the posters from the manufacturers up there on how to clean, but they don't follow it. So it's like, what's wrong with that picture? You need to transport from the point of use to your cleaning area, unless it's all the same place, in a closed biohazard labeled container. You want in your soiled or clean or hopefully not combined utility room to be from soiled receiving through washing, through drying, through high-level disinfection with no crossovers, and the flow going from dirty to clean all in one direction, so nothing gets put in the wrong place and misses a step. And I've seen that happen more times than I care to count. Thorough cleaning with the proper equipment. You guys don't usually have to deal with brushes and lumens and things like that. That's a wonderful thing. But you need to be sure that you're getting all the gel and secretions off the probes, regardless of what they're used for. Soak time and temperature for high-level disinfection. You need to have a timer, you need to have a thermometer, because some of the high-level disinfectants say 12 minutes, but it's 77 degrees Fahrenheit, and you know, that may not be the temperature and probably is not the temperature on the counter in your cleaning area. So you would then need to increase the soak time, and if there isn't a table in the written instructions, I would contact the manufacturer and ask for those instructions. Okay, our average temperature is 69 degrees. How many minutes does that translate into for high-level disinfection? And the timer gets set when the last item goes in. You can't put one thing in and time it and then add a second or third item and still take the first thing out 12 minutes later. It has to be the last item goes in, the timer is set, and it's left undisturbed until that full time has elapsed, whatever the manufacturer says. You need to monitor the high-level disinfectant concentration. There are dipsticks to do that, and you have to quality control the dipsticks according to the manufacturer's instructions. That is something I see. The other thing I've seen with not sonographers, but with techs, is very dutifully write down the MEC, fail, 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 day after day after day. They were told to record it, not that there was something special they had to do, like change the solution. I'm serious, you can't make this stuff up. So you need to be sure if you've got people working for you who do some of those tasks, that they get it, that they understand if it's failed, this is what you have to do, or at least come get me and I'll tell you what you need to do. You can't make this stuff up. So the test strip quality control is another thing I see a gap in. And the documentation process, you need to be recording the time that you put it in, the time for cleaning, the time you put it in, the soak time, you know, et cetera, so that you have a log that demonstrates that you're following proper procedures. And you want to protect that process device. You can put it in a Ziploc bag, you can put it, you know, wrap it in plastic, but Joint Commission especially is looking at this. They want to see things protected between uses, so just be aware of that. And training, competency evaluations, that people are competent to do the jobs that they're doing, and that there is a procedure and a competency for each special piece of equipment that you have, or a general competency if you've got people working for you that are doing some of the cleaning things for you, which would be nice. So with manual cleaning, obviously you need to wear personal protective equipment, at a minimum gloves, gown and eye and face protection if that is necessary based on what you're cleaning. The cleaning must physically remove all the debris and the lubricant from the probe, and cleaning is the first and most important step before high-level disinfection or sterilization can occur. If it isn't clean, you can't sterilize it or high-level disinfect it. There is no magic in the high-level disinfection solution or the autoclave that will clean it. It's got to be clean before it goes in, otherwise it just bakes on and organisms can remain in that crust that's on the device. So you need to follow the probe instructions for cleaning and disinfection. You need to follow the high-level disinfectant instructions. So if there are conflicts there, you need to look at other high-level disinfectants or talk to manufacturers. Remove and discard the sheath of the condom, wash the probe, and often it says wash with soap and water. Some say wipe down with a low-level disinfectant, whatever yours says, and then soak in the high-level disinfectant, as we've talked about. And we've also mentioned the handle may be contaminated, so ideally your probes would be fully submersible so that you can disinfect the handle as well. And I'm going to talk about another thing as well here as we go on. And again, once it's done, you want to protect it from contamination. So here's a story on the handles that they are not routinely immersed and they grow all kinds of nasty things. They're just awful. The use of an automated device can reduce the contamination to background levels on the handle. And frankly, if I'm coming to your center for a vaginal ultrasound, I want to know that the handle was processed too, because I don't want HPV, thank you very much. I have enough trouble. So the clinical staff needs to have an idea and consider the need for handle disinfection. As I mentioned, some of these are sealed, so they can be soaked. Some of them are not, so high-level disinfecting ends at the business end of the probe and excludes the handle, and that's a bad thing. And then this is another reason why infection preventionists should be at the table when you're buying new equipment, so we know that it can be properly processed to protect our patients. So we have lots of high-level disinfectant solutions, glutaraldehyde, there's a lot of brands, orthophthlaldehyde or OPA, also many brands. These require special ventilation, air exchanges, because they're pretty toxic and people have difficulty with them. There is 2% activated hydrogen peroxide. Recert XL is the one product I'm familiar with. There may be newer ones coming out as well in competition. Peracetic acid or the Steris 1E, which really isn't designed for ultrasound probes. And the last one, the Trophon 35% hydrogen peroxide, offers a tremendous amount of insurance, if you will. We know that OPA and glutaraldehyde may not kill HPV the way we thought it did, and we're waiting for some more studies on that to come out. The FDA has not taken action yet, but I know in my last facility we switched over to the Recert because we were concerned about that and made sure that we were using something that was safer for the staff as well as effective against some of these other pathogens. So the automated high-level disinfectant systems with hydrogen peroxide, it kills HPV and other multi-drug resistant organisms. It's a sonicated hydrogen peroxide with no toxic byproducts, and that to me is a plus for the users, because they're not going to get exposed to the fumes and the issues. Some of you, I'm sure, already have issues with using glutaraldehyde and OPA. So it's a short cycle. It's 7 minutes, which means your turnaround time is faster. It includes, as you can see from the picture, both the probe and the handle. It gives you a computerized record, and I was at nominating and awards committee for APIC earlier in the year, and one of the gals there, she said, we just switched everybody in my system to Trophon. She said the record keeping alone is worth it, because keeping those logs of the high-level disinfect, I see people nodding, oh, I hate those logs, they forget to fill them, they don't fill them out, and then I have to try to go back and fill in, you know, that kind of thing. And it does come with an internal indicator, so you know that it was a good process when you open the container. So for the minimum effective concentration test strips, or for the Trophon, the dots, the chemicals can get diluted in the soak basins, but with Trophon, there is no dilution because there's a fresh cup each time, you know, fresh product each time, which is great. Be sure you're not using your test strips beyond the expiration date, and even if it passes, you know, you dip it and it still says pass, if it's the expiration date, you have to dump it. You cannot keep using it because it passes. So the expiration date is a hard stop, and you need to replace it when you're using glutaraldehyde or OPA or Recert. QC test and document when you're opening a new bottle of the test strips, and you don't have to do that with Trophon. And as I said, discard the solution even if it passes the test. So monitoring competency and practices is essential. Make sure all your staff is trained, even the ones who fill in. When I go to endoscopy centers, I love hearing, oh, Stanley's in the back today. We love it when he's processing those scopes because he can turn them around in 10 minutes. And the high-level disinfectant says 12 minutes soak time. So he's cleaning and disinfecting and all that. Yeah. And then we have the problem with the doc standing behind the tech who has a high school education saying, I need the scope, I need the scope. It doesn't need to soak for 12 minutes. Give me the scope. And that's a problem, too, because often the tech doesn't feel comfortable in rebutting the physician who pays their check. Just saying. So make sure you document training and maintain those training records and periodically observe practices to be sure that they're being done correctly. So in summary, to ensure patient and staff safety, develop and implement policies and practices based on recognized standards that I showed you for cleaning, disinfection, and sterilization. Base the protocols on the intended use of the item that you're working with, and follow all the manufacturer's instructions for use. Ensure that personnel understand and follow all those guidelines and practices. Monitor compliance. And as I mentioned, the automated hydrogen peroxide system offers many advantages. And Trofon has a wonderful article that somebody who did the cost analysis, and it came out very favorably on return on investment. So anyway, that's all I have, and we're going to hold questions till the end.
Maybe one question right now, or we'll hold.